This is a quick summary of ARVs and building an ARV regime. If one looks at the three rows, we're going to start with the bottom row. If one ignores Eluvia for the moment, because Eluvia is normally used as a second-line agent, and one focuses on efavirenz and niverapine. Niverapine used to be used for women of childbearing age because efavirenz was considered teratogenic. Now, that's no longer the case, so even women of childbearing age can get efavirenz, and even if a woman is pregnant on efavirenz, you do not need to switch away. So let's go back to niverapine. Niverapine has a nickname. Its nickname is nasty. And it's nasty because it has skin and liver side effects, which can be mild to severe like a Steven Johnson. We also know that at higher CD4 counts on initiation, there's an increased risk of these nasty side effects. So on the package insert, it says that women should be started only with CD4 counts below 250, which is why we do not use niverapine in post-exposure prophylaxis, because people might have higher CD4 counts. So we're also interested in the liver function of a patient. That, in summary, is niverapine. Efavirenz, or efavirenz, has neuropsych effects: sleepiness, dizziness, bad dreams, psychosis, and in some places people even smoke it. Patients who are with chronic psychiatric illnesses seem to fare quite well on efavirenz, but it could be debated whether or not it should be used in patients with acute psychosis. Another issue is occupation. If a person is a bus driver, security guard, or waitress who works at night, these could be important to the patient, but this shouldn't prevent the patient from receiving efavirenz, because people can actually tolerate efavirenz quite well. But the patient should at least be warned. If they cannot tolerate it, then one might consider niverapine. Efavirenz is also preferred in TB treatment, because the rifampicin is a powerful inducer of cytochrome P450, which will marginally chew up niverapine more than efavirenz, particularly when one takes into account that niverapine is normally started at 200 milligrams daily for 2 weeks, and then it becomes 200 milligrams BD onwards. So when one is on efavirenz, which is only 600 milligrams nocte, one can start immediately with the dose that one needs to. However, if you happen to have a patient who's got a acute psychosis and is on TB treatment, one could actually consider starting somebody on niverapine 200 milligrams BD immediately, as long as their liver function is alright. Let's move on to the third drug on this row, Eluvia. It's made up of lopinavir and ritonavir. And ritonavir is an inhibitor of cytochrome P450 to boost lopinavir in the blood. What's more important is that if a patient is on rifampicin, which is an inducer of the enzyme, it will want to reduce this level in the blood. So if somebody's on RIF, one has to double the dose of Eluvia. So instead of taking 2 in the morning and 2 at night, the patient must take 4 in the morning and 4 at night. The 4 by 4. You'll get this car analogy very soon, because Eluvia is a potent antiretroviral, and it's very important that those should be doubled in the face of rifampicin. In essence, that is the bottom row, and you can see that liver metabolism plays a role in the bottom row. Another point: if a patient has a mild rash to niverapine, it is not difficult to switch the person to efavirenz. If they have a severe rash or Steven Johnson, they might be switched to Eluvia in the hospital setting. If somebody has a rash to efavirenz, then one would see if it would be transient and will go away with time. However, if it seems to be severe with mucosal or conjunctival involvement, then one would consider switching to Eluvia in the hospital setting. That is the bottom row. 3TC we'll discuss a little bit later. If we move to this top row, I'm going to take you back in history to the 1st of April 2010. Before the 1st of April 2010. And we're going to start with D40 because it was the default. Because D stands for dirty. Yes, it was dirt cheap, which is why we got it. And it had lots of dirty side effects. Peripheral neuropathy, lactic acidosis lipodystrophy. Lactic acidosis made D dangerous, and particularly for women whose BMI was over 28 on initiation, particularly when the dose was 40 milligrams BD, there was a high risk of lactic acidosis around 12 months after initiation. Fortunately, the dose has been reduced, so we don't see much of lactic acidosis anymore. However, if somebody had a BMI over 28 before the 1st of April 2010, they were going to be initiated on AZT, or if they were pregnant, because the obstetricians didn't trust AZT, and they were started on AZT if they were pregnant. And you could start AZT as long as the patient was not anemic. That was the majority of first-line antiretrovirals before the 1st of April 2010. And there's some stories behind the antiretrovirals. For example, if you see a woman who started on efavirenz 5 years ago, one could consider that maybe they had TB treatment when they were initiated. Or if you meet a man on nivirapine, one might consider, did they have a psych problem or an occupational reason for being on nivirapine? If one finds a woman on AZT, then one might consider, is it because of BMI? Is it because of pregnancy? Or did they have a side effect of D4T? Now, when these first-line regimes were being switched to a second line, it was noted that hepatitis B might flare up because 3TC also had activity against hepatitis B, which was a reason for the introduction of tenofovir before the 1st of April 2010. And one could do that as long as the patient's creatinine clearance was over 50. So, tenofovir came into the system before the 1st of April 2010 if the patient was hepatitis B positive or had a side effect of D4T or AZT and eventually moved to tenofovir. Now, if you happen to be HIV positive and you had to choose your antiretrovirus for yourself, and which ones would you choose from these 3 rows for yourself personally? Yes. What one chooses is tenofovir, 3TC, efavirenz. Tenofovir can be taken as a daily dose, 3TC as a daily dose, and efavirenz as a daily dose. And these 3 pills can be taken all at night. And since 2013, we have a fixed drug combination where all the 3 of these drugs can be found in one pill. The only exception is that instead of 3TC, it's called FTC or intrasibine, which is a 3TC lookalike and acts in basically the same way. So right now, antiretroviral choices after the 1st of April have in essence become that. If a patient has a renal impairment and the creatinine clearance is below 50, one can consider AZT. However, the patient got renal impairment and a low HB, or there's a risk of the HB dropping, then one can consider using D4T. And that's how it works now. You go down this line, whereas before it was up the line. In private, instead of going down the line, if there's renal impairment, they tend to use abacavir, which is an expensive agent, which is why we have limited access to it in the public sector. Now, when it comes to taking the antiretrovirals, if a patient is not adherent for various reasons, half the time it's because we haven't explained the way the antiretroviral should be taken properly, or the patient has themselves had factors that have contributed to the fact that they didn't take the antiretrovirals properly. If the virus goes up in the blood, one would have to decide whether or not to switch to a second line, which would involve Eluvia. And as the virus would begin to understand how these antiretrovirals work, one develops the mutations which learn to dodge these antiretrovirals. It only takes one mutation to dodge these two. It only takes one mutation to dodge this one. And it only takes 4 out of 6 mutations to dodge these two. The similarity being that the T is a thymididine. And these mutations are actually called TAMs, thymididine analog mutations. So before the 1st of April 2010, when tenofovir wasn't universally available, the old second line before the 1st of April 2010 was AZT, DDI, and Eluvia. And one can see that there are if you've already developed mutations to D40 AZT, you're now using what the TAC called a compromised second line. DDI. D stands for dirty. So if you use 2 D agents, you have double dirty. And Eluvia is your 4x4. Even if you don't use Eluvia properly for a year, Eluvia still will be useful after a year and still be potent enough to suppress the virus. However, when tenofovir became universally available, tenofovir and DDI are both adenosines, so one cannot use these together. So what was decided was, let's drop DDI and continue 3TC, because 3TC actually has a nickname. The C stands for crippler. And it's called a crippler because the mutation that happens to the 3TC actually cripples the virus by 30%, which is actually a good thing. So after the 1st of April 2010, antiretroviral choices were as simple as this now. D4T, AZT, tenofovir, 3TC, efavirenz, niverapine, Eluvia. And if you can think of those 3 rows, you will know what you need to know. So let me give you an example. If a patient happened to be on D4T, 3TC, niverapine, and one would have to choose a second line because one has addressed the adherence problems, then it would be Eluvia, 3TC, and tenofovir, if there's no renal impairment. If somebody was on tenofovir, 3TC, efavirenz, then the second line would be Eluvia, 3TC, and your best option would be AZT. Now, when one thinks of tenofovir, before you can switch away from tenofovir, you need to think of 2 things. Yes, the one is the creatinine clearance, and the second thing is the patient hepatitis B positive? If they're hepatitis B positive, one needs to continue the tenofovir on top of this regime. And then there will be these 4 agents. Another thing, as an aside, if a patient has an intractable diarrhea on Eluvia, an option to be considered is to switch the patient to atazanavir and ritonavir. The ritonavir boosting the atazanavir in the blood. This gives less diarrhea, and the only drawback is that this cannot be used in the face of TB treatment, which involves rifampicin, because even if you double this dose, rifampicin induction of cytochrome P450 will chew it all up. The options are either to switch back to Eluvia if there was TB treatment, or to use an agent like rifabutin. Another side effect of atazanavir is an asymptomatic hyperbilirubinemia. But if the patient is willing to tolerate that over having an intractable diarrhea, then this is a very good option. A nice thing about this option is that tenofovir, 3TC, atazanavir, and ritonavir can all be used as tablets at night. Hopefully this was a very quick, brief summary of the story of antiretrovirals.